Hello and welcome to Maggie and the students that have been assigned to PMR my topic. It's called the Critical Appraisal of Evidence for Electrical Stimulation for Dorsiflexors in Stroke Patients. So just to give you a bit of an understanding, so it's easier to understand what I'm talking about, neuromuscular electrical stimulation is the application of an electrical current through electrodes to induce a muscular contraction. So in the case of stroke patients where they've lost the ability to volitionally control their own muscles, you can use electrical stimulation to help them return to a state of, for example, mobility in gait with stroke patients. Functional electrical stimulation is the use of such an electrical current to help rehabilitate ankle motion, strengthen and weaken muscles, and used in rehabilitation for stroke and spinal cord injury. The second half of the topic is weak tibialis anterior dorsiflexor causes foot drop. So we have our thigh here, we have our knee, shin, and the foot. So tibialis anterior is here and causes the foot to move that way to cause dorsiflexion. Weak dorsiflexors cause it to drop into plantar flexion, so move that way and rely on gastroc and soleus. And this causes foot drop, so the foot drags across the ground, and this can cause gait problems and is a barrier for rehabilitation in stroke patients. So functional tasks such as treadmill training with functional electrical stimulation has been demonstrated to be effective in rehabilitating stroke patients. So just to expand on that little drawing I did earlier, here we've got tibant, and here are the electrodes that connect to the electrical stimulation device. And when this is contracted, the foot moves this way. So that's how functional electrical stimulation works. One question we always have to ask ourselves when researching any topic in health is it relevant to the health of the public? So stroke is the leading cause of disability in Australia, and in 2012 over 420,000 people were living with the effects of stroke. So not dying from, living with the effects of it. 2/3 of these people subsequently had a disability which impeded them to carry out activities of daily living, and you can imagine the emotional toll this has on a person. It is estimated by 2032 that over 700,000 people living with stroke, 2.4% of the population. And the total financial cost of stroke was close to $5 billion in 2012, with healthcare and care costs costing $1 billion and loss of productivity close to $2 billion. So we have an ethical, financial, and medical reason to investigate this topic. Using that same statistic again of 420,000 people in 2012 living with stroke, 232,000 were male, 187,000 were female, and if you were male, 25% more likely to suffer a stroke. If you fell into one of those 4 age groups listed there, you comprise 53% of all strokes in Australia. And then there's just some additional risk factors for stroke, such as high blood pressure, physical inactivity, cholesterol, diabetes, poor diet, high body mass, tobacco, and pollution. Nothing really surprising. High blood pressure alone did comprise 6,602 deaths, which is quite substantial. And the disability adjusted life years here is just a measure of overall disease burden, expressed as the number of years lost due to ill health, disability, or early death. So once again, just from blood pressure, and approximately 60,000 years of healthy years of life lost due to early death or disability. So the stats for stroke. In terms of mortality, stroke is Australia's second biggest killer after coronary heart disease, and it accounted for 75% of all cerebrovascular disease-related deaths in 2011. Mortality rates are high compared to other first world countries such as Switzerland, and typical of the Scandinavians such as Sweden, Finland, Norway, and even some of the European countries like Germany and France. They had much better mortality rates, so there is a room for improvement. In terms of mobility, same statistic as earlier, approximately 75% of stroke survivors can't work due to disability. This is huge in terms of money lost, and 30% suffer post-stroke depression, and it's easy to see why so much quality of life is lost and so much money is lost. So why is it interesting to me? I have absolutely no quarrels with the idea that prevention is always best, such as with pretty much everything in healthcare, but there will always be stroke, and certainly numbers may increase with an aging population, also given the lifestyle factors and the obesity rates in Australia. I find it interesting because when there's always an argument in health, it's always weighing up one side against the other, but this is such a one-sided argument. In the government's eyes, it makes sense to have people return to a state of autonomy and independence so they can return to work and the government earns more money. In the patient's eyes, restoration of independence ensures well-being and quality of life, and you really can't argue with that. And in my eyes, as a budding health professional, we have an ethical, medical, and financial reason to help their rehabilitation. So the search terms I used were stroke, functional electrical stimulation, or dorsiflexors, and this yielded 133 records across PubMed, Medline, Cochrane Library, which databases we're all familiar with, as well as Pedro. And Pedro is the physiotherapy evidence-based practice database, which yields something called the Pedro scale. And this is becoming more of a gold standard in physiotherapy's movement towards evidence-based practice using the Pedro scale. So that's why I've included it. Inclusion and exclusion criteria. There had to be an application to the lower extremity dorsiflexors in at least one of the experimental groups, and this could be in conjunction with a functional movement. Stroke patients only, no multiple sclerosis or cerebral palsy. Systematic reviews are randomly controlled trials. There were no systematic reviews that met the inclusion and exclusion criteria, so they're all randomized controlled trials anyway. Last 5 years to keep evidence nice and recent. Must have had a control group to compare interventions. You'd be surprised how hard it is to find some of these studies with a control group. And then I didn't care if it was acute or chronic, both were included. After inclusion and exclusion, 3 articles remained. So just a bit of clarity so you understand what I'm talking about in the next article. This here is bodyweight support treadmill training, and this apparatus here will take up a percentage of the person's body weight so they can have a gradual return to load bearing. So once they suffer their stroke and they start rehabilitation, this machine might take up 80% of their body weight initially, and this decreases over time so they can have a gradual return to load bearing. Here's the functional electrical stimulation device, and here are the electrodes that will stimulate tibialis anterior during swing to correct for foot drop. Robot-assisted gait training is very similar. Here's the bodyweight support apparatus, and these things here are part of the robotics side of it, and these only allow a certain amount of range of movement through each of the joints throughout the gait cycle, and this is controlled by the therapist. So with those 2 pictures in mind, the justification and relevance for Article 1, the bodyweight support treadmill training is too labour intensive, and there's the belief that robot-assisted gait training is potentially more supportive of a normalised gait. And no study had been done on the combination of robot-assisted gait training with functional electrical stimulation. So that was the justification for this study. The study design consisted of 13 men and 7 women from the Samsung Rehabilitation Centre in South Korea. So a private centre, Samsung's quite big on robotics, which I'm assuming that's why they're there. Inclusion criteria, walk 10 metres with or without an assistive device, such as a cane, cognition sufficient to understand instruction, but more importantly, give consent, and 6 months after stroke event, and they could perform the test. So 6 months after, this is quite in the chronic stage of stroke rehabilitation. Exclusion criteria, poor body systems such as arthritis, circulatory problems, cancer, and other serious comorbidities, and of course mental capacity. They were either randomly assigned to the experimental group, robot-assisted gait training and functional electrical stimulation, or just the control group, and there were no significant differences before the intervention. Outcome measures consisted of quantitative and qualitative gait assessments, and they did the intervention for 30 minutes a day, 3 days a week for 5 weeks, along with conventional physiotherapy. Continuing on, the sample size 20 is quite small and the mean age is low, 45 to 50, and this is not at all representative of the age groups that actually experience stroke the most, so this opens it up to some design bias. No statistically significant differences before the intervention, which is good. Participants were randomly assigned, which is also good, and a single blind, so there is possible therapist bias. All 3 articles I talk about are actually single blind. And I read another article that bypassed doing single to double by purely not telling the therapists which person was in which group. So I'm actually kind of baffled as to why one of the 3 articles that I talk about didn't actually use that for a double blind. Possible risk confounding. They praised the experimental group, although not statistically significant, and it's possibly due to unknown variables. Level of evidence, NHMRC class 2 of evidence, randomized control trial, and the Pedro scale is an 8 out of 10, and I'll go into the Pedro scale on the next slide to explain it a bit better. However, you really have to take this with a grain of salt. The authors did not attempt to rectify their bias or even acknowledge them, and they're quoted as saying the only limitation of study is that the gain analysis was not explained thoroughly enough. So I would probably appraise this at a low to medium level of evidence just based off that. So this is the Pedro scale, which is very specific to physiotherapy evidence-based practice. And I've done this for all three of the articles just to give them a decent idea of the weight behind their study. So they have to satisfy the eligibility criteria to actually receive a Pedro score. So this number 1 isn't involved in the score out of 10. This is just eligibility for the actual Pedro scale. So this is the inclusion exclusion, which the previous article got a yes. Subjects were randomly allocated. Allocation was concealed for them. The groups were similar at baseline. Blinding of all subjects, blinding of therapists, blinding of assessors. Measured at least one key outcome for more than 85% of the subjects initially allocated, so taking into account dropout rate. And for all subjects for whom outcome measures were available, received the treatment or control condition as allocated. If not, then there was an intention to treat. The result of between group statistical comparisons are reported for at least one key outcome, and they're both point measures and measures of variability for at least one key outcome. So that's the Pedro scale. So just another bit of clarification before I go into the next article. This is mirror therapy, and so what's happening here is this is a single-sided mirror, so the paralyzed limb will actually be on this side of the mirror, and what he's going to do is he's going to look at his good leg and look in the mirror and try to trick his brain into thinking that this is his right leg. And he'll activate something called mirror neurons. And what mirror neurons are is they respond to the observation of a person's movement as if in response to a real movement. So in actuality, we'd have the electrical stimulation device trying to stimulate this tibia. And when it's stimulated, he's going to look in the mirror and hopefully trick his brain into thinking that the right side is actually moving. And you can use this for things like arthritis to try and alleviate pain. It's as also with phantom limbs as well. So it's quite common mirror therapy. So with the mirror therapy diagram in mind, the second article justified its use by saying mirror therapy has been shown to improve function in upper and lower limbs of stroke patients. And the authors investigating the use of functional electrical stimulation with mirror therapy, as this is together not known. So the study design was 30 subjects taken from Ilji University Hospital in South Korea. And this is a really baffling problem because they haven't included their exclusion-inclusion criteria, which immediately in Physioland completely discounts the article. So it's really strange that they didn't include that. And the outcome measures were various gait measurements. They were randomly assigned to 3 groups. Experimental group had mirror with functional electrical stimulation, experimental 2 just mirror, and the experimental 3 was sham treatment, so false treatment. 30 minutes a day, 5 times a week for 6 weeks. And as always, they received conventional physiotherapy as well. So sample size, 30 people is more reasonable than the last article, although there is no mention of where these people came from and what excluded them from the study. So there's a pretty serious inclusion bias there. Again, age is low, which opens it up to the presence of design bias. Single-blinded study, so therapist bias, and it makes claims that are not founded on evidence that is statistically significant, so there's possible unknown variables once again. The article says things like it's statistically significant, but then later on in the conclusion or discussion says that they aren't and that they're better than the other group. So I'm making the loose assumption that because it was written in Korean, there is a possibility that it's been translated quite poorly into English. Level of evidence, NHMRC, class 2 of evidence, randomized control trial. Pedro scale 0 out of 10 because there is no inclusion-exclusion criteria. Its external validity is compromised. It cannot be applied to the wide world. It is not evidence-based practice. But they do acknowledge the limitations of sample size and generalizability. So At least there's one redeeming quality, trying to control for the design bias. Given all this, I'd probably appraise this article at a low level of evidence. So once again, a bit of clarification to understand the next article. So this is 4-channel FES. So in the previous two studies, they've used a 2-channel to just stimulate the dorsiflexors. All channel means is how many electrodes, so in this case 4. So here they've got the dorsiflexors on, but they've also, looks like they've got lateralis and maybe rect fem or vastus medialis being stimulated. What's strange about this study is they did it in a side-lying position, so they haven't made it functional. And when I talk about some of the results, you'll see why they came out the way they did. I think just purely based off that. So with the former picture in mind, the justification and relevance for this topic, they acknowledge functional electrical stimulation as an established means to treat foot drop, but they believe that the over-focus on tibialis anterior, so dorsiflexion, during the chronic phase of stroke leaves behind other muscles. So they have a subsequent decrease in knee flexion, hip flexion, and ankle plantar flexion, propulsive forces in gait. So long story short, other muscles are being left behind, and it's affecting gait more than it's actually helping. So subsequently, they decided to use functional electrical stimulation to treat dorsiflexors as well as other lower limb muscles. Study design consisted of 368 people, and after inclusion and exclusion, 55 remained at the Sun Yat-sen Medical Hospital in China. Inclusion, stroke, aged 45 to 80 and within 3 months, so acute to subacute phase. Exclusion, progressive lesions, cancer, serious comorbidities, same as the other studies. Single-blinded randomized control trial, patients were blinded. 3 groups, a 4-channel, which had more muscles groups, dual channel, which was just the dorsiflexors, and the 4-channel placebo, and they went for 30 minutes a day, 5 days, 3 weeks. Stimulation in sideline, which is quite unusual. They haven't done anything that's really functional, such as bodyweight support dremel training, so you can see why the results pan out they do. They also received conventional and occupational therapy. So as for the sample size, they did a power analysis of sample size and figured out they needed 52 people in total in 15 in each of the 3 groups. Only 45 completed, however, so it lacks some statistical power in that respect. Still the largest study out of the 3, and actually credit to them for doing the power analysis when the other 2 didn't. And age is actually much more representative, averaging 65, which is about right, so it's less bias than the previous 2 studies. Single-blinded study, so there's still that therapist bias hanging around. It actually suffered the placebo effect because in the sham group, which had the 4 electrodes, they actually did better than the dorsiflexion group. So researchers noted their inverted commas surprise, and they highlighted some psychological interest in rehabilitation, so they do attempt to ameliorate that bias. Results between 2-channel and 4 were statistically significant, but not between 4-channel and control. So the researchers don't overextend themselves, and they do acknowledge that there is some statistical significance, but they don't, like the other 2 articles, try and make ridiculous claims about how useful it is. Same NHMRC, and the Petro scale was 7 out of 10. Because they acknowledge their limitations of sample size, dropout rate, and no objective measures, there seems to be much more honesty in this article than in the previous 2, so I'd actually rate it at probably a moderate to high level of evidence, despite not actually showing much of a benefit from just the dorsiflexors, but possibly in the 4-channel group, so including other muscles. Just to conclude, NHMRC was class 2 evidence for all 3 because they were randomized control trials. Petro scores were 8 out of 10, 0 out of 10, and 7 out of 10. And when taking into consideration things like study population, justification, study design, intervention outcome, findings and limitations, I appraise the overall quality of evidence of this subject at mixed. It doesn't seem to be the best method of treatment for stroke rehabilitations when you have just the stimulation of dorsiflexors. Taking into consideration the last article, I think that the area needs to go into multiple stimulation of different muscle groups while doing something functional like treadmill training or robot-assisted gait training. Thank you.